to a lot of the issues with community treatment orders. So involuntary treatment is when I would be mentally ill to the point where I might be out of touch with reality. I might be psychotic. I might be hearing things, seeing things, believing things that are not true. And because of that, I could be a risk to hurt myself or hurt other people. And maybe the basis of my illness is such that I don't want to seek help. I don't think I have a problem. I'm afraid that medication will poison me. I think somebody's out to get me, those sorts of things. And I don't want to be admitted. But there's legislation that provides situations or guidelines as to if that situation is occurring, then I could be admitted involuntarily. There's legislation about treatment authorization and refusal. What could I refuse? Whether or not I'm an involuntary patient. Can I be treated against my will? In some provincial jurisdictions, I could be admitted involuntarily, but the facility and their representatives would not be able to treat me involuntarily. Here in Newfoundland and Labrador, I could receive treatment involuntarily, so I could be made to be given medications and things like that. And again, lots of ethical concerns about that. Rights and safeguards, the rights of the patients, the rights of staff, the rights, safeguards in place there. Of course, community treatment, including CTOs, and mandated service and other provisions such as confidentiality and restraint. Okay. So getting right into community treatment orders, after giving you that basis, I hope I didn't go too fast, but everybody with me so far? Okay. So community treatment orders are a form of mandatory outpatient treatment. So it provides a legal way of making sure that if I'm an individual with a mental illness and I need treatment in the community and I'm refusing it, there is a legal way that you could make me get treatment. And that treatment could involve me going to see my physician, seeing the community mental health nurse, taking medications, those sorts of things. So a community treatment order is not treatment. Okay, and people seem to think that it's a form of treatment, and it's not. It's a legal way to enforce that person in getting treatment. Okay, so does that make sense? Okay, and these laws often have dubious origins. Some of the laws, for example, there's a law in Ontario. It's called Brian's Law. Brian is the name of a CBC sportscaster who was killed by an individual who was experiencing psychosis. And so now the law is on the books. It's called Brian's Law. And so that law is now down in record as memorializing a death that was, perpetrated by or caused by an individual with mental illness. And so I'm really glad our legislation didn't go down that path. But it certainly adds to that, in my opinion, the criminalization of mental illness. And we can talk a bit about that later. I don't get into that too much in this talk, but if you have any comments or questions about that, by all means, I'd love to hear them. And a community treatment order can be enacted under a variety of conditions. So these are, some of the common things that I've seen in the literature, including the Centre for Addiction and Mental Health, which is a leader in Canada for mental health work, care, and research. So in terms of these conditions, situations in which persons with severe persistent mental illness frequently become mentally unwell to the point of posing a safety risk to themselves or others, often due to treatment non-adherence. So they're not taking their meds, for example. That's the big one. That's the most commonly cited one in terms of treatment non-adherence, and who therefore require frequent readmission to treatment facilities. So in Canada, community treatment orders are not for the person who just shows up to the door and is, experiencing psychosis. I would have to, and I keep using myself as an example. I don't have psychosis, but I always like to use me as an example. If I went up if I was an individual with psychosis, maybe I had schizophrenia, maybe I have a repeated history of hospital admissions. Every time I go in the hospital, I get better, I get put on medications, I get stabilized, I get discharged, I stop taking my medications, I get sick again, I get readmitted, I get back in the hospital, and this is my pattern. I would be considered for a community treatment order under this legislation. Okay. Then there's other reasons, and to assist with integration into communities, so to help individuals who have had lengthy histories of hospitalization or repeated long stays of hospitalization to get back into the community and reintegrate, and to learn various different skills. Just keep these in mind for our discussion, because this will come into play with some of the points I want to make. Decreasing admissions and length of hospital stays, and thereby reducing costs, making hospital beds available to others. Okay. Cost-saving measures. Improving prognosis by decreasing periods of untreated psychosis. For example, with schizophrenia, it takes months for an individual to recuperate after an acute exacerbation of schizophrenia. So just like when you go in the hospital and you have your hip replaced, you're not going to go out and jump over the fence, 2 weeks after you have your hip replaced. It's going to take a lot of recuperation, a lot of rehabilitation. It's no different for anyone who's had such a major impact by a mental illness. So it's going to take at least, the literature is saying, the research is saying, at least 6 months of stability and taking medications and whatnot in order for the brain to heal. And so, ideally, we don't want people mentally unwell for long periods of time, because it makes the situation in them and their illness more difficult to treat and to get better and to function again. And decreasing traumatic aspects of hospitalization and concerns regarding public safety. So in mental health, the group here has heard of it, but we talk about survivors of various different things in our society. And there's a body of literature in mental health that looks at surviving the mental health system and what people endure while they are in the mental health system. And I certainly don't want to paint the picture of the mental health system as being entirely negative or entirely bad, but certainly some people have had better experiences than others. And stigma is alive and well everywhere. And so, we really want to combat that even within the mental health system and make sure that people get good care when they need it. Proponents, individuals, and groups that support community treatment orders say that these measures are less restrictive than mandatory outpatient admissions and are therefore in accordance with the Charter of Rights and Freedoms. That is a debatable comment. It depends on how you look at what is considered to be less restrictive, and again, something to keep in mind for our discussions later. But the idea of being housed in a mental health facility, not able to leave the unit, being on locked units. Many units are locked in various different facilities, not just here in St. John's, but across the country and elsewhere. Mental health units are locked units where people cannot come and go as they please. There's a lot of restrictions, restrictions on your liberties, and it's done with the under the goal of keeping the individual safe, keeping the environment safe, and keeping other people safe. So certainly, the idea is if we can get people out in the community, living well in the community, well, that's much better for them. And the goal is to have people in the least restrictive situation possible. And when you look at the Canadian Psychiatric Association's position paper that supports mandatory outpatient treatment, this is a statement that supports that, and it says that anything that we do must be clinically and ethically appropriate to take a preemptive approach to reduce the risk of serious harm to the patient, and although less common to others. Any questions so far? Oh, great. Perfect. Grand. So I was also asked to give a perspective of where do we stand in terms of Canada. Again, understanding the legislation. Many national and provincial associations are in support of community treatment orders. And the Schizophrenia Society of Canada, for example, has generally been in support of community treatment orders. Certainly not carte blanche, but in terms of the concept of providing treatment in the least restrictive situation possible, they've been supportive of that. The Canadian Mental Health Association has been a little bit more skeptical about community treatment orders. And there's concerns that it does erode the rights of individuals, and we have to be very careful in terms of that and how community treatment orders were enacted. And the Canadian Mental Health Association's idea and selling point is if adequate mental health system, if it was in place, community committal would not be needed. Okay. And some would argue that it's a little bit more complex than that, but there's certainly a lot of weight in that comment. In terms of Canadian provinces, we all have in our legislation the outline for how we can involuntarily admit someone to a hospital. So that's not a bone of contention here. But not all of them have, in the Mental Health Acts, have provisions for community treatment orders. Okay, Saskatchewan, Ontario, Nova Scotia, and Newfoundland and Labrador, and Alberta has this legislation. And Saskatchewan was the first province to implement this in 1995, sorry. And some variances exist on how they are implemented, but they have them, okay? Some provinces have provisions in their legislation for extended leave from hospital. So that's kind of like you're on a pass, you're not really discharged, but you're on a pass for so many weeks, you touch base, you come back, then you're on your pass again. And this could be extended passes for lengthy periods of time so that you're not truly discharged from hospital. You're living out your admission in the community, okay? And then there's provinces with no stipulations or for community treatment orders or for hospital leave, and that's New Brunswick and the Three Territories, okay? All right. And again, when you look at the legislation, we have to have that criteria for who's going to be on a community treatment order. They have to meet the psychiatric history criteria. There has to be a treatment plan. There has to be identification of services and supports for the individual. There has to be verification of that rights advice has been given. So, you're right as a person who's being considered for a community treatment order. And there has to be notification that consent or authorization for the order has been obtained. And I'm going to get into this part. This has been a bone of contention in Newfoundland and Labrador with what I found in the use of community treatment orders. So this is a very busy slide, but this gives a little bit of information about the actual nature of the legislation, how it works. I can give you a little bit of information about that. So the individual must have a history of mental illness and require ongoing treatment or supervision in the community. If such care was not provided, there must be an identifiable risk that the person would become harmful to self or others. The person, because of the severe mental illness, would have to demonstrate a lack of insight or understanding into its nature and the need for treatment, and therefore she would be unlikely to voluntarily agree to treatment. And if the person does not avail of such services, then her mental status and level of functioning will continue to deteriorate. And in Newfoundland and Labrador, it's been identified that you have to have at least 3 involuntary admissions in 2 years or have previously been on a community treatment order in order to be considered. So that's Newfoundland and Canada. And I'm just going to briefly tell you about how that relates to elsewhere. There's community treatment orders are being used in Australia, United States, New Zealand, and the United Kingdom. There are variations in its use. For example, in Australia, you don't have to be an inpatient. I could be an individual who is seeking services as an outpatient, and maybe I haven't been taking my medication regularly, they can intervene earlier with a community treatment order than they can here in Newfoundland or Canada. Okay, and of course you'll see the usage rates in Australia are quite high. And for example, in Saskatchewan, approximately 2 per 100,000 of the population, whereas in Australia it varies. In Tasmania it's 30.2 per 100,000, and in Victoria it's 98.8 per 100,000. So it's quite a bit of difference in the rates, and this is where a lot of provinces in Canada who do use CTOs are running. Okay, so quite a bit of difference. And then on the rise. So not only are they being used more frequently in some areas, but then once they bring them in, they over the past number of years, we're seeing increases in their use. In New York, they've been increasing. In England, they went from 3,325 to 4,291 in the span of a year. Okay, so their use is catching on. And my question is, well, is that a good thing or a bad thing? What's going on here? So finally, to the study. I hope you got enough background information now. Okay, so to the study. So as you mentioned, my background is in acute care mental health. And for the past number of years, I've been taking students to acute care mental health settings, nursing students, both in the baccalaureate program and the practical nursing program. And over the past number of years, with the introduction to legislation, kind of been wondering what's really going on with the community treatment order use. I heard tell of it being considered for some patients. It wasn't going to be used. There were problems with using it. I remember back to when the legislation was being considered and all my thoughts regarding it. And so when I started to do my PhD, I was interested in ethics and mental health. And then my thinking started going down this path with community treatment orders. In Newfoundland, it's used very infrequently. In the past couple of years, it's been considered more and more, but it's been used infrequently. There's been a lot of confusion as to how to implement it, especially in its early days. And people are starting now, I think, starting to understand a bit about the concept of deterioration and the idea that if you don't have services, you will deteriorate in the community. And what does deterioration mean? And in the legislation, it's supposed to mean psychological and physical deterioration. What we're actually seeing in practice is a bit different. And so what I was seeing was that there was a disconnect between what was supposed to happen with CTOs and what was actually happening. And so I wanted to find out why this was happening, what was really going on. I used institutional ethnography. I'm not going to discuss that. Anyone who's ever heard me talk before about this, I talk a lot about the method, but I'm not going to talk about that. But I'm just going to say I did a number of interviews with a variety of individuals who had experience with treatment orders. And I reviewed a multitude of documents, legislative documents, policy manuals, United Nations documents, various different forms, whatever I could get my hands on. Found a number of documents related to CTOs. A lot of reading. A lot of highlighters ran out. So this is what I found, people. CTO legislation is not focused on therapeutic outcomes. It's not about therapeutics. It's a piece of legislation. Now, there's a body of research and study that's called Therapeutic Jurisprudence, which identifies the whole idea that there can be therapeutic effects from legislation, and we talk a lot about that in mental health. But really, the legislation in this case is to make sure that the person engages in treatment. And even within that context of therapeutic jurisprudence, there's debate as to whether or not something is really therapeutic. So, for example, if I'm an individual who's forced to take medications that have serious side effects in terms of movement disorders, maybe I'm incredibly sedated. Maybe I'm so sedated after I take the medication, I might wet the bed at night. I drool. I feel very uh, conscious of myself and it's affecting my socialization, is that really therapeutic for me to be forced to take those medications? And the thing is, a lot of those medications are what's covered under the formulary of what's approved by the provincial government for individuals who may not be able to afford these medications. Psychiatric medications, I don't know if any of you are familiar with them, but a lot of them are very, very expensive. And so if you're suffering from if you're experiencing a mental illness to the point where it's impacting on your ability to work and you don't have insurance, well then you're in a hard situation for being able to afford your medications. New medications that are coming out now that are injectable, that's being promoted for individuals who don't take their pills, they're $12 to $1,500 a pop, one shot, one needle. So if you're on that every 6 to 8 weeks, that's a lot of money. So what is really, what's therapeutic? What is therapeutic? And there's this whole idea of risk for harm that's being identified, that we're trying to protect the public from somebody who could potentially harm them. And the literature is certainly showing us that individuals with mental health concerns who, if they do engage in any type of potential harmful behavior, the potentially harmful behavior is more so a concern against themselves than against other people. Now, you're always going to find and hear tell of somebody who had a mental health concern who was harmful towards somebody else. Yes. But individuals with severe mental illness in particular are more likely to be victims of violence than the perpetrators of violence. So we really have to fight against that stigma and that misunderstanding as well. Okay. So the first priority is protecting somebody from harm, and it's all about physical harm. So again, this idea of deterioration. If I'm not doing well and I'm just quietly in my home, not causing any trouble to anyone, and I'm flying under the radar in terms of what I'm doing, I would more than likely, I asked this of a number of individuals who are familiar with this legislation, who use this legislation, who implement this legislation, who care for individuals affected by this legislation, would I be considered for community treatment order? And they all said no, at least not very likely, because you're not causing trouble or you're not causing harm, or even though I'm deteriorating myself, I'm not causing harm to other people. And so this legislation follows the whole idea of, protecting others from harm. Then there's also the idea that no one who's been on a community treatment order in Newfoundland and Labrador has been discharged from it because they were better. So people have been discharged from community treatment orders because they didn't fulfill the requirements of the legislation. So maybe they stopped taking their medications, they stopped going to their appointments, and it was identified that they were breaking the order, the undertaking, and then they could be brought back to hospital. But to my knowledge, and I've asked this, and as best as the information that I've been given, no one's been discharged because they were better. Okay, so this is in the literature. There's lots of inconsistencies in the literature in study results regarding community treatment orders. Some studies say that it works. I have a light here. Oh, awesome. So, and of course, for those of us who are familiar with research, randomized controlled trials are considered to be the gold standard in any type of research. And there's been a very small number of randomized controlled trials that have been done looking at community treatment orders. And even when you look at the findings here, lots of variability. What is most important, though, when you see it, is the fact that people engage in their supports, their resources. So if people have services and supports motivated around them, they will tend to do better. So what is the most important thing here? Is it the fact that the person's being legislated and being forced into engaging with those supports and resources, or is it the fact that they are there and they're able? Is it really the forcing or the fact that they have them? Okay. Now, the reality is not everybody's going to engage in treatment. You're always going to get someone who's going to say, no, I'm not going there. I'm not going to talk to that person, whatever. So, that's a reality, but it's more so having the supports in place. That seems to be the crux there. Then there's differences in opinion of self-reported experiences of those who have been involved with community treatment orders. I'm eventually going to have a sip of my water. I've been holding it for a while. I'm afraid to lay it there. Computer here. And this lack of consensus, there's lots of confusion regarding the community treatment orders. I'm a nurse. I'm not someone who's well versed in criminology, in legislation. I know enough about legislation that I have my RN Act. I know what I'm legally allowed to do and what not to do. And there's even some things there that every now and again you have to check and make sure what your scope of practice covers. And I'm sure anybody else who's here who's a regulated health professional is aware of that. But I don't walk around thinking legalese. I don't speak legalese. I'm not a legal expert. That was a big learning curve for me in doing this project. So how do we enact the legislation? And sometimes the translation of what people would like to see in legislation, what actually gets into legislation, what's translated from that legislation into policy and procedures, and then the forms that we fill out in terms of the forms that are signed by people to say that they're on a community treatment order. There's a real trickle-down effect that's happening. And sometimes things get lost in translation. And so that confusion really comes out in this study. And I keep talking about this whole process of the trickle-down effect of this legislation. I don't know about you, but I used to be in Brownie's guides, and there used to be, I think I've used this example, so my apologies to anybody who's heard this example before, but there used to be a game that we'd play that you'd start saying something, and you go around the room, and by the time you see what happens when it comes back to the person who started, and it was never like anything that it was started. So with not just with CTO legislation, any type of legislation, there's always a risk that the ideas and the concepts and the wishes of the people who are involved in being consulted and being involved in creating legislation, that actually being put into legislation, and then the trickle-down effect into the practice of everyday people. Sometimes there's stuff lost in translation. Okay? Everybody good on that? Okay. So there's no certainty that, when we have a CTO put into place, that it's going to have good outcomes for patients. And again, the idea of having those supports. I think I'm getting ahead of myself a little bit in my discussions. Sometimes I should probably just have one line and just let me talk. But again, if this is going to be available for people, having that information, having the citations and stuff like that, you're more than welcome to them. So again, regardless of a service being mandated or voluntary, it's the nature, quality, and extent of the service that is important. Okay. Then there's this rhetoric surrounding the community treatment order legislation being rights-based. And I use the term rights. What does that really mean? And when you look at a definition of that, it means that it's reflective of valuing the autonomous choices that patients can make in relation to their care. So is the CTO legislation rights-based? It's being promoted as being rights-based. There are individuals who are in place to make sure that, or their role, I should say, is to make sure that individuals who have been put on a community treatment order or who have been involuntarily admitted are aware of their rights. So they have individuals who can come to hospital and sit down with me and say, Nicole, you've been put on a community treatment order. Do you understand what that means? I can give you some information about that. Okay, here's some information. And so these are things that weren't in the previous legislation, which when you look at it, it's a move forward. But again, some of that is challenging to keep up and maintain in the practice, and making sure that people get that information in a timely manner. If you're talking to someone who's acutely psychotic at the time, how much information are they taking in? How much are they understanding? Things like that. So, what is truly rights-based? And when you look at the legislation, it's more from a utilitarian perspective, not so much from an individual perspective, but it's more about the greater good. Okay, and you're trying to balance out that with the rights of the individual. But with a lot of legislation that you will see, it's the rights of the many, the good of the many that outweigh the good of the few. When you think about, could I text and drive and be safe? I don't know. We probably have tried to. I don't want to get anybody in trouble, but certainly that's not to say that everybody can do it or that everybody should do it. And legislation says that we can't do it. The distracted drivers legislation. Okay. So again, the whole idea of protecting the public. I just want to give you this information though, and some of this is a bit conflictual, but I just want you to think about this. When you think human rights, there's the UN Declaration of Human Rights, and it supports the argument against CTOs by identifying people's rights to life, liberty, and security of person without undue interference. Okay, so there's concern about CTOs from that perspective. However, when you go into another article of the UN Declaration, Article 25, it talks about people's right to an adequate standard of living that includes health, food, security, and shelter. So again, if I'm an individual who's suffering from a mental illness, that by the very nature of its illness, it's impacting on my cognition, my ability to rationally think, my ability to take care of myself, the ability for me to cook, clean, do the things that I need to do in my everyday life. Should I not get treatment for that if it's impairing my ability to rationally say I need to get help? I'm not saying yes or no. I'm just putting it out there for you to think about. Okay. Then there's the rights of the person with disabilities in 2007. I don't know if people are familiar with that document. A lot of us have heard about the UN Declaration of Rights. But in Article 16 of that document, it talks about individuals with disabilities have a right to be free from exploitation, violence, and abuse. So the evidence is saying that as a person with severe persistent mental illness and as a person who might be acutely psychotic, I'm at risk for harm to myself, let alone other people, but to myself, and I'm more at a risk to be a victim of violence. Should I not make sure that, or should society not make sure that I'm healthy so that that risk is reduced? Again, not saying yes or no, just putting that out there for you to think about. Articles 19 and 28 focus on the living situations of individuals, including community inclusion, freedom to choose their living arrangements, and a reasonable standard of living. So again, when you look at CTOs, they infringe upon these liberties in the sense that patients can be directed to live in certain areas where services are available. So again, if I live in a far off corner of Newfoundland where there's no community services available for me, could I be forced to move to Gander, to Grand Falls, to Stephenville, to St. John's in order to avail of more services? And I'm sorry for anybody who's out there in Gander or Grand Falls or Stephenville, but there's not a lot of services out there either. Most of the services that you see for mental health are located within the greater St. John's area. There's some supports out there, but certainly not to the extent that are needed. And certainly the services in here are not to the extent that they are needed either. So, there's that concern. There's also the concern that, well, if we do force somebody to move, well, then they'll be able to get the services that they need. And they'll be able to increase their potential to do well and recover from their illness and engage on their path to recovery. So again, is that right? Is that a good thing to do? Again, I'm just putting that out there. And then Article 9 focuses on individuals' abilities to live independently and be active participants in their lives. So while CTOs can be restrictive, CTOs can be a means of ensuring the person accesses treatment that can foster her ability to be a full active participant in society. So again, this is these are documents that if you're looking at the confusion surrounding community treatment orders and the ethics surrounding legislation, these are documents that are both supporting and refuting the ethical basis of this legislation. Okay. Then there's the Charter of Rights and Freedoms. I'm presuming that people are familiar with that. This is the penultimate piece of legislation, if you will. Every law in Canada has to fit within the Charter, has to be in accordance with the Charter. So again, Section 1 says that, it guarantees our rights and freedoms, and Section 2 identifies everyone as having fundamental freedoms. And so again, when you look at the Canadian Charter of Rights and Freedoms, there's evidence to suggest that it's against community treatment orders in terms of restricting liberty and freedom. However, it could be challenged that in the purpose of CTOs, if the purpose of CTOs is to restore true liberty and autonomy by treating mental illness that is responsible for interfering with liberty, freedom of thought, and true autonomy, then could we not support legislation for CTOs? Okay. So getting at this confusion, and it's much more than just saying CTOs are right or wrong. It's quite complex. Some patients, as I mentioned, will never fully or even partially participate in mental health treatment and services, even if compelled. And so that can put a lot of strain and stress on individuals who are out there trying to provide that care. So I spoke with nurses who spoke about their frustration and other health professionals who spoke about their frustration with the idea that we're supposed to be, and of course I came at this from a nursing perspective. I just want to put that out there for social workers and everybody else in the room. There's this overriding ideology of nursing as being a caring profession. Okay, so we hear about that a lot. Nursing is a caring profession. So how caring am I if I'm forcing somebody to take medications? If I'm going in there and saying, you know what, if you don't take this, I'm going to have to call the police, and the police are going to come and get you, and you're going to be brought back to the Waterford or wherever. How therapeutic and how caring is that? So there's lots of concern about that. And so somebody who actually says, yeah, okay, fine, I'll take the medication, are they really then participating in their recovery? Are they really engaging with their healthcare provider and their healthcare services? I would argue not. Compliance does not equal engagement. And then there's our professional power. I mean, so basically we're using, and the literature is called therapeutic leverage. Very nice, innocuous threats that many health professionals use. And we have that knowledge of what's going to happen if you don't take your meds. We have the knowledge of how the legislation works and how we can enact the legislation. And again, that's a real struggle for a lot of health professionals. And speaking from a nursing perspective, it's a lot of challenges for us as well. We're not all nurse ratchet, okay? If you want to think back to One Who Flew Over the Cuckoo's Nest, the second greatest villain of all time is a nurse, psychiatric nurse, which doesn't say much for us, but yeah. So, and then we talk about the therapeutic relationship. Nursing talks about it a lot. I'm sure social work talks about it a lot. Engaging in that therapeutic relationship and how we can do that. So again, if I'm engaged in this, using my professional clout to try and keep people complying with treatment, is that relationship really therapeutic? Okay, and there's a whole slew of research that gets at the therapeutic relationship and mandatory treatment. And I'm noticing that I'm starting to get close to my time. Yep. So I'll move along. I won't read out so much. I mean, they'll be on the website, so you can have a look at it there. I'm getting close. And family members. We cannot ignore the issues that family members or the concerns that family members have in terms of this legislation. even though individuals have, there's been this shift to providing care for individuals in the community and wanting to put more healthcare resources in the community, in reality, the care responsibilities are falling to the family members. And the family member is the face of the community treatment order in many cases. It's the husband, the wife, the mother, the father, the sister, the aunt, whomever, the grandmother, who is trying to keep things going for that individual and trying to keep them going to medicate to appointments and things like that. And so if the family member wasn't doing this work, a lot of this would fall apart. And I mentioned about the confusion regarding the community treatment order use. I will say this, the community treatment order is an undertaking. And there's a spot on the actual form where the patient can sign it. And it's meant to say that I am understanding that I'm being put on this community treatment order. Lots of confusion as to whether or not a person who is an involuntary patient, can they actually sign a legal document legally? I wouldn't be able to sign a mortgage if I was psychotic. So would I be able to sign this for myself, saying that I understand that I'm going to be engaged in or forced into treatment? And some people were looking at it as consent. And so there was lots of confusion regarding that. And then there's this whole idea of legislating recovery. And for those of you who are in the mental health field, there's a real focus on the recovery model or using a recovery model and acknowledging that getting better is not a point that you want to attain. Recovery is a journey. And so just like any recovery from any type of chronic illness, you have points where you're doing well, you have points where you're not doing so well. There's you're on this process of trying to maintain your wellness at your optimum level, whatever that optimum level is. And so the recovery jargon and literature starts getting thrown into all of this in terms of, the CTO doesn't really force people into maintaining the recovery. And so, again, if you have somebody who is really not having a good quality of life while they're living on a community treatment order, are they really in the recovery phase of dealing with their illness? So I would argue that it clashes with the recovery model. So in terms of future considerations, third last slide. So this is what I'd like for you to think about. There's a challenge for nurses and other healthcare professionals to deliver care under an under-resourced context. And we're hearing that now. We're hearing that with the budget. There's been some cutbacks in terms of mental health care. There's a lot of fear out there that it's going to get worse. And so if we're legislating care and if we're legislating treatment, ideally the treatment has to be out there. And we have been able to, in some ways, secure more resources for the legislation in terms of there's been more community mental health nurses that have been put in place since or prior to the legislation coming into effect and since then. But we're finding that even with those increases, we're really taxed. And so there needs to be a better distribution of supports. And in the context of Newfoundland and Labrador, where you have such the population is so dispersed, it can be really challenging to do that. So we have to be really not just ensure that this resource is there, but we might have to be very innovative with how we provide those resources. We have to support individuals who are providing the care and support. So support the supporters, support the caregivers, because without them, this whole thing would fall apart. That's a strong statement, I think, but certainly we cannot underestimate the importance of informal caregiving and supporting the caregivers. And so groups like Schizophrenia Society of Newfoundland and Labrador, you're integral to providing that support to families of individuals with mental illness. And so how can your organization be supported further in doing the great work that you're doing, for example? Terms and conditions of community treatment orders need to be made clearer. Certainly, if there's lots of confusion, we need to deal with that. The whole idea of Therapeutic focus in recovery. Let's call it what it is. It's law. It's not about recovery. It's not about therapeutics. This is a law. And so let's try and get away from this whole vernacular that we're using that, let's call it what it is. Okay. And so, again, making sure that people are provided with that information, because I am not a legal professional. Many of us are not legal professionals. We need to have that information. If we're going to be using this legislation in practice, or any type of legislation in practice, we need education about it. And so, and this goes beyond what we get in our basic programs. And while, yes, you might say that it's incumbent upon us as if again you're a regulated health professional to learn that information as part of your continuing competency. Again, you might read that document and not have a clue what it means, in terms of interpreting the document. So having support for that. And again, the work of family caregivers needs to be addressed. So to conclude, the CTO, the use of CTOs is not for frontline mental health issues, okay? It's used for individuals who are further down the path in terms of the severity of their mental illness. It affects a small portion of the population, but that portion of the population is significantly impacted. Their families are significantly impacted. And so in terms of resources, it's not just resource intensive from the perspective of hospital admission rates and the costs on the system, but it's also human resource costly in terms of how families are affected and supports. And when you look at what's happening in community treatment orders and the issues surrounding community treatment orders, it's really what's happening with mental health in general, but it's magnified, it's more intensive. But when you look at sports issues, when you look at resource issues, when you look at funding issues, when you look at understanding, mental health, when you look at understanding medications and support for medications, and non-medicinal treatments in terms of like counseling and things like that, we're seeing the big picture of issues that are facing individuals with mental health concerns. Certainly, CTOs is very much an intensive example of that. And so we can't ignore what's happening in terms of the CTO legislation. And I think if we start exploring what's going on in terms of what's happening with CTOs and the challenges there, we might come up with ways of being innovative and creative and problem solving as to some of the other issues that we're experiencing in the mental health system. So thank you.
Thank you very much, Nicole.
I didn't mean to go that long. Sorry.
That's okay. As John is switching on the switch for the microphones here, I'll just say one thing that I think is really important. As somebody who works with policy day in, day out, I can say this with fact. Laws reflect our values as a society, and those laws that deal with the most vulnerable and minorities are the ones that best reflect our values. So while it is, quote, only legislation, I think it does reflect how we feel about ourselves and about the most vulnerable. And having said that, there's many a slip twixt the cup and the lips. We may have wonderful intentions, but in practice, maybe they don't work out. So I think maybe that's part of the problem here. So